All right, good afternoon or good morning. We are going to start our task force today on AI. This is September 10th meeting. Be sure to silence your cell phones if you have them with you. And remember, those of you who are speaking this morning, to turn on your mic so we can know that you're here. Does anybody have any guests you'd like to introduce? All right, seeing none. Do we want to have a roll call?
Senator Meredith. Present. Senator Smith. Senator Storm. Senator Thomas. Here. Senator Williams. Representative Blanton. Here. Representative Lewis.
Here.
Representative Miles. Here. Representative Stevenson. Senator Mays Bledsoe.
Here.
Representative Bray.
Present.
All right, looks like we have a quorum, so let's go ahead and approve the minutes from the August 13th meeting. Can I get a motion? Thank you. Get a second. Thank you. All in favor, please say aye. Any opposed? That motion carries. All right. Today is Healthcare Day in the AI Task Force, and we are so pleased to have a variety of different speakers and perspectives on looking at healthcare both in the private sector, in our insurances, and then how we as a state cabinet are using it. And we're going to start with Cody Bumgardner. So if you want to come to the podium, Cody. He's the director of the Center for Applied AI, and he's going to discuss how we're using it specifically at UK, and you have the floor.
All right. Everybody hear me? Okay. How about now? Yes? No? It is. Green button's on. Now? Test. There we go. All right. I'll put it right in my face. Yeah, I'm happy to be here, and as a native Kentuckian, I'm glad to see that this topic is getting a lot of attention. So as a director of Applied Center, I'm not going to talk about future things. I'm going to talk about things that exist today, things that we're developing. And I want to set the stage in this spectrum of AI because it's a very broad field. Some is very narrow. So you have purpose-built tools that are very safe. They're used. There's over nearly 1,000 FDA authorized medical devices that use AI. Although in most cases, what makes the news and has in the last 6 months or a year is this idea of generative AI. And this is the topic where models and artificial intelligence can take information that is maybe it's not directly trained on or trained in pieces, and it tries to bring those things together. So that also can be used in medicine, but we have to be careful about how we do it. I will not get into general artificial intelligence, which maybe can exist, maybe it doesn't exist, but it certainly doesn't exist now. Okay. What I'll do is go through a couple of projects that we've worked on that exist in practice and how we're using them. One of these is predicting extubation readiness in preterm infants. Now, this is important because this is one of the use cases for AI where there's a lot of data. You can imagine a preemie is hooked to lots of devices. This information is streaming, so there's not one report that you can look at and make some determination of when is the right time. So in this case, we're using AI to look at over the course of a day or a week, when is the right time to extubate a baby? When can it breathe on its own? These are things that no amount of training can let you take in the amount of data that would be required to make the best estimate for this to happen. So it's a good use of applied AI. Another one is a model and then device that we are working on, and this was published fairly recently, assessment of trauma. And this was, you require typically experts to read a sonogram of somebody that's gone through some sort of a trauma to determine at what level with this fast ultrasound protocol, how bad a shape are they actually in. Well, with this model, what we've done is developed it to where you can make that assessment. The model will tell you, are you getting the right reading? Is there a trauma, and what level of trauma you have? Now, the point of this would be, and you see this currently making its way into devices, and this is the more narrow field AI, where it would be making some assessment that wouldn't be as good as an expert could make, but maybe it's sufficient to determine whether somebody should be maybe airlifted to level 1 trauma center or not. So this is the type of AI that takes expert annotation and information and tries to impart it into a narrow field model that can be used elsewhere. It can also be used in hospital operations. At the University of Kentucky, it's common for us to take transfers from other hospitals, other locations. These are non-emergency transfers. And in this case, it's also common for lots of hospitals to have all the beds full. So the problem we're trying to address from an operational standpoint is, do we know a day ahead of time or 2 days ahead of time what the demand's going to be on the hospital beds? How many people are going to be at certain states? What we found was that using statistical methods, this was very difficult to do. And our predictions didn't work. We couldn't tell how many people would arrive at a particular time in the ER. Using newer artificial intelligence methods, once again with time series data, looking at previous history, not just how many people arrived yesterday, but also precipitation, air temperatures, or snow. Was there a UK basketball game? We can very closely determine a day in advance how many people are going to arrive at the emergency department, something that we can control, so that we can make adjustments on how many people would be transferred. There are other strategic things that we can do. There's some of you may be aware of CMS measurement scores and star rankings. These are our measurements with peer institutions to determine there's a gap payments between what Medicare and Medicaid pays, and as part of value-based medicine, a determination of how well you do as a system is part of this measurement score. So we created a optimization system using AI to determine if there are going to be investments made in things like providing devices that go home to somebody to reduce 30-day readmit, or things like how long you wait to get a bed assignment. Those are things that we can control, and we created systems to go back and say, if we had made these investments previously, what would have been our optimal ranking, which would then be a measure of how well we're doing related to public health and peer institutions. So these are all part of AI. Another forecasting one that is in the public health arena, we have a grant. There was a large HEAL study, then there was an offshoot grant called RADOR that was to provide real-time information on overdosing. And this is done on a county, and in some places area within cities, to forecast how many, specifically how many overdoses, or if there will be spikes. And there's certainly latent information we see. If there's a overdose in one area, then it can be related to another. Using regular statistical-based approaches, you have a really hard time forecasting when these spikes will occur. Once again, using what they call covariates, which could include seizure information, information related to what's happening in other counties and other cities, even weather information. There's some correlation between how long that there's been sunshine and whether people overdose. That we have some good good AI methods to predict when spikes will occur and the relation to other locations. I will bring up, and this is always part of the ethical AI question, how well does it work for certain populations? This was one where we found, because we had data provenance going back, that there were differences in different populations for the accuracy of these models. So especially in healthcare, this is where we can't get just a pile of data and say this is people with a certain disease. Medicine is more complicated than that, so you typically need to transfer that provenance of data all the way through, and then study that like any other laboratory test. This is an area that generative AI, what makes the news, is based on foundational models, and if I can express anything today, it's the importance of making sure that foundational models of medicine represent people of Kentucky. And the way foundational models work, the way that the chat GPTs work, the way that large vision models would work, is they take as much information as can be possibly found. They train it in a model, and I don't mean train as in this is a cat, this is a dog. The data just goes in. So the reason they call them foundational is that it's trying to take any relationships that can be found within that data. Could be the position of words, or it could be the positions of pixels in an image, and then it provides a representation when you can then of that information. So if you think about it, it creates a blueprint. From a medical standpoint, if you have a certain condition, some pathology, a foundational model would provide some specification or some blueprint of that disease or that pathology. If it's a written report, there would be some information that says a profile of that information. If models are generated in medicine that don't contain the specifics of people in Kentucky, then they won't be able to properly profile and blueprint those people, so they can't be used in downstream models. I bring this up because this is where most of the, I would say, a lot of the investment and a lot of the whiz-bang things that you see that make the news are in foundational models and generative AI. And this probably holds the most promise of anything over the long term, because it allows us to take laboratory data, case data, text data, image data, genomic data, and put it all together for particular patients and groups. So once again, we need to make sure that Kentuckians are represented when these models are generated. Where we're getting probably the most mileage out of AI right now is AI assistants and agents. And you can imagine most of you have gone to ChatGPT or one of those and asked some sort of questions. These are not the answers that typically we want from a medical perspective, but the underlying reasoning and human understanding of language still works the same. So for patients, we use it to interpret questions, so that not that it answers the questions, but when somebody says the same thing 5 different ways, it can be derived to the same standard response. Allow it to provide curated information. So if you have cardiology guidelines and a person doesn't know how to ask the question like a cardiologist, they can distill the question into something that we can provide curated responses back. Also distill these responses. If we're asking surveys or questions, how do you feel? People respond lots of different ways. It's a human intensive task to take and distill that information into things that we can operate on from a computational or informatic perspective, but AI does it very well. Same thing with a provider. Summarize information, locate information, do discovery. If we're doing genomic variant interpretation, there's volumes and volumes of data published all the time that people have to go through. This is something that AI does a good job. Same thing with clinicaltrials.gov and matching up patient profiles with the clinical trials. We have several projects on this that are clinical in nature, and we have ongoing trials that are research that are active right now. The very simple one is to get compliance on drugs before cardiac surgery. This is a text message or a phone call that normally would be a person. We find that it doesn't happen as often as possible, or at least doesn't get recorded, which has now been extended into, this part is in the development phase, at least from a clinical standpoint, into more reoccurring contact with the patient. From, does somebody need to call you? Do you understand what's happening? Do you understand your procedures? So we're going from a piece of paper being given a month or weeks prior to surgery to something that we can follow up and engage with somebody, and at any time they can ask for somebody to call them and speak to them. This is more future, but we've also started working with robots, and I think this will head towards some humanoid that is now gone from kind of science fiction to starting becoming financially feasible. This particular robot platform was developed to roam around hospitals and elder care facilities to do telemedicine visits or even voice calls with families. They have LiDAR. They can bounce around and go from room to room. They're also used in other countries to take people to say, I need to know where radiology is. They have LiDAR and can go and take the person to radiology. We've equipped them with smell sensors and vision models, so they can determine if people have fallen in the room. They can smell certain ammonia and other things that probably shouldn't be present in a person's room, and patrol that and provide additional information. So I think you can see in the next 3 to 5 years these things becoming a pretty commonplace. They already are in certain areas. I do want to kind of end with what other people are doing. This was fairly recent. There was an effort by New York, which is the Empire AI Consortium, 10 years, $275 million investment to create an artificial intelligence computing center. University of Florida was a big one in our area, $140 million from the state to build new data centers, $15 million a year from the state to hire 100 new faculty. The majority of those faculty were in health colleges. And Oregon State, also $70 million in state paid bonding for a collaborative, innovative complex. So these are, to participate in AI, you need major investments, typically on a state or national level, to be able to really compete in this area. Considerations, which are questions, not necessarily my feelings. Historically, there are lots of states. Ohio has a supercomputing center. Texas has TAC. There are lots of them that have high-performance computing centers. In 1987, there was one established at the University of Kentucky, and to my knowledge, the funding for that organization has not changed since then, and at least it hadn't in the 27 years that I was there and when I directed the group. So the question is the time right to do a computing center at Kentucky to do the same? From a patient perspective, the literature shows that patients are concerned far less about their privacy when they're very sick, and Kentucky is full of sick people. So privacy is obviously very important, but anybody that's worked in the space knows how difficult, even within your own institution, it is to access patient data, even that you have appropriate rights. Now, part of that is there's lots of penalties that in the last 10, 15 years that we've forgotten the portability part of HIPAA, and it makes it really technically difficult to get access to this data. Recent final rule from HHS that actually has specific disincentives for information blocking. So I think this is a good step, but there wouldn't be this legislation if it wasn't a problem. You can't do AI unless you have access to data. It's not possible. From a state perspective, we do automatically enroll cancer patients in registries because we consider it a big enough problem that it's worth doing that. People can opt out, but by default they're opted in. Should we do something like that with the identified data for all patients in Kentucky? Kind of going back to that foundational model, these things can be built without ever leaving the hospital and still shared, meaning they can be completely anonymized, but still benefit the Commonwealth and the patients. State laboratories are commonly overseen by people in academic areas, even though they're within the state. Should we have an extension of the state laboratory to do certain AI testing? Should there be some expertise, support, or tools for clinical validation of AI across the state? There was recent Nature publication that went through the process of FDA approval and was pretty critical about the requirements that they, in many cases, did not feel that there was clinical validation of those tests, which, once again, if it's a test that is not, if there's approval of a test that does not work necessarily with the Kentucky population, and those aren't working very well, then we need to ask whether that's appropriate for our state. We probably need some internal expertise for that. So that's all I have to say.
Thank you so much. I've seen you present several times now, and I find such really interesting things that UK is doing in this space and providing patient healthcare, which is what we want. I have one question. When you talked a little bit about the assistance for patients after surgeries and follow-up, do you find that their model's better, the patients are actually healthier because they're responding more often, they're doing what they're supposed to do from a follow-up perspective, or on the pre-side?
Well, the surgery one would have been in place, but it's now expanded. What I can speak about are the research studies that are also clinically focused, and those are in different areas. And we had started out with one of the aims would be, do people participate? Do they respond? Do they have better outcomes? And the second aim was, what are the likelihood of people to basically drop the program and not responding? We had to cut out the second aim because people were not they were not participating. So what we found is that if there's an engagement, that people can find value and get some information. So this isn't just somebody sending you a random text to survey. This is something specific towards your health, your program. And that's where I think the automated assistants come in, is that it's no longer a system that's doing something for the system. It's something that's tailored towards you. It's a virtual assistant for your health. So I think that there's more engagement in those areas than we would have thought.
That's interesting. Senator Thomas, do you have a question?
I do, Madam Chair, and thank you. Dr. Bumgardner, I came today with the $64,000 question, and that is, people want to know today whether AI can be used to find hard-to-diagnose ailments. For instance, someone comes to the doctor and says, I've got a problem with my back, doctor, and the doctor can't find anything wrong with the back. Or I've got severe headaches, my head hurts all the time, and the doctor can't find problems with what's going on with those headaches. I mean, can AI now be used to find hard to diagnose diseases? Because people want to know that. There's something wrong with me. I'm hurting, but the doctor can't diagnose what it is. Can AI be used to find that diagnosis? That's my question to you.
Yeah, and I don't want to quote this particular paper because it caused an uproar, but there was a big publication that talked about rare diseases, complex diseases, and physicians alone, teams of physicians alone, physicians with AI, and AI alone. And depending on what you believe, it could have been any three of those folks. But I think the answer is that it should. And the reason being is that people, I think from a neurology standpoint, you can get around some of this with advanced training. People cannot do conditional probability. You can't make decisions on things. 5 to 6 to 7 points of data is about the best a person can do. I can't take 10 balls, throw 10 balls in the air, and you tell me where they're all going to land. And I think that's where we are with lots of the data in the medical subspecialties. There's so much information. There's so many different groups. To have one person or a team make a complex diagnosis that they don't see is very difficult. I'm not sure that AI, or we don't want AI making those decisions for us. I think they want us taking monstrous amount, volumes and volumes of data and distilling it down to where people, informed people, trained people can make those decisions. So I think as a tool, short-term tool, absolutely. As things go forward, and that's part of the generative AI, and we've seen this in materials discovery, is that the AI, as long as a human can verify it, it may be able to generate diagnosis that we can then distill billions of potential options down to hundreds, and then people can trace it down. Was that a good answer? Yeah.
Thank you. Senator Meredith.
And how many hours do we have for this meeting? We've heard a couple of meetings so far about the bias in the data. Who has the responsibility for assessing the data and determining whether there's a bias?
It depends on who you ask. What I would say in clinical tests, it's very clear who has the responsibility for establishing the test and doing the test. Now, that if it's a FDA-approved test, that's more of an acceptance than an actual creation. So I think that there's responsibility throughout the system, but if you're looking at it as a clinical test, there's already established pathways for who's responsible for making sure that the test works as expected for that population, and that it continues to work for that population like you would any other laboratory developed test. Mm-hmm. Now, there's FDA guidance on good machine learning principles and also guidance on how we create software as medical devices. Those are mostly for narrow AI, the types of things that are repeatable tests. When we start getting in this land of taking lots of generative AI and looking everywhere, it's not clear, and that's part of the comments I made on more of a state-wide view of how we collect and curate data, is that we need that provenance of data going back from the origin all the way through the model development to know that it works well. A model might work well for somebody if it was collected in Japan and it's trained on people in Japan, but it may not work for people in Kentucky. So at this stage where it's being developed everywhere, we have to have that provenance from end to end, from the beginning of the data being collected all the way through the testing, and then not just once, but like we do other laboratory tests, over and over and over, making sure that it doesn't deviate and something hasn't changed.
One of the concerns that I've learned is possible overdependence upon AI by practitioners, and it's kind of the lazy way, and we're all guilty of that. It's easier just to go in the computer and try to come up with something, but if that could occur, should occur, then if there's a misdiagnosis or an inappropriate plan of treatment, who has a medical liability?
I think it depends on the application. In the narrow field, I don't see much distinction between using AI of saying, in a very specific case, then we have automated laboratory testing. At that point, too, the automated line could maybe have a fault, but it's done so many times, and we trust it that we believe that it's going to work and it's okay. Mm-hmm. When we look at this and say we have not tested what generative AI is going to do across large populations, across every piece of data we can find, then it makes it a lot more difficult to say what would happen. I personally don't think we're anywhere near the point of turning over healthcare to AI. I think that we can use it to distill information. We can use it to engage with patients to make sure that we're speaking the same language. We can use it as virtual assistants. But a lot of this should probably not be, in the generative sense, making diagnosis, maybe making suggestions. But what we do is we make sure that that AI is pulling from specific real data. So it's not something trained in the model. We're using it more as an assistant to say, put these 5 pieces together and then show me if it makes sense, and then I can verify. So going back to the trust and verify from that standpoint.
Well, certainly it's logical, but I think AI has unlimited potential. But I think where we'll lose a little bit of control of this is with greed, because somebody's going to want to make a buck off of it, and that's when things start to fall apart. And that's why I wonder where the liability is going to eventually end. But to that end, with all this massive data that you've got to have for this and will continue to grow, who has ownership for the data?
It's a complicated thing. I don't know the answer to that.
Well, and if it becomes a proprietary database and whoever owns that is not willing to share that, does that provide a potential disruption in care?
Well, I think we see that in social media. The people that have the data are the ones that can control the best models and generate things. So I think we do need to take responsibility of doing this within our own systems. And as I mentioned with the foundational models, those are things that can be trained at institutions across Kentucky, can be trained at the state, and then shared without worry about actually having your personal data. So it would be like everyone across the state picking up a rock in their yard and putting it in a bucket and sending it in. I would never know that it's your rock, but I would know that there was a representation across the state of what it looked like. So I think there are safe techniques, there weren't 10 years ago, there weren't 5 years ago, that we can get most of the way of where we want to go from a power of AI without exposing people individually and having a competitive advantage on 1 or 2 groups.
I think we can as well, but it's kind of the wild, wild west right now.
Yeah.
And unless we have some, I think, federal intervention and some guardrails on this, I'm not sure which direction we will head, either for the good or for evil. But thank you. Great presentation. Thank you, Madam Chair.
Thank you. Senator Smith.
Yeah, just a quick comment on one of the questions that Senator Thomas had mentioned earlier. With the medical aspect, I mean, AI is going to be as sharp as data and stuff that's obviously added to it, and it'll develop as that goes. And the concept of getting as much data in it as possible is what drives up the value, like what we saw with the Chappie sort of program. But good data is great. Bad data is something that you have to be worried about. But I like to think of years ago when my daughter was sick and we spent a lot of time in Johns Hopkins and multiple hospitals, the doctors would just get exhausted. They would try different things and some of the stuff would fail. So what they do is they would bring us into these group meetings. So they would bring in doctors from multiple fields and we would have this sort of sit down, and then they would all just try to look at it from a completely different, sort of direction or different department of the medical field. And so now fast forward all these years later, that's really where AI could come in, is overlooking something like Behçet's or an unusual Middle Eastern disease that you would not normally think about being in Eastern Kentucky, but as you dive into it, you realize many years ago, Middle Eastern people passed themselves off as Indians to be able to get work. And so that's the uniqueness of it, is that AI can uncover lost stories that a doctor may be so close to it that wouldn't. But again, the data for us is going to be critical. I may push back on a little bit about federal oversight, because we've seen what happens with the Facebook deal when you have federal oversight pushing in for an agenda, manipulating the data that goes into it. So there's some concern there. But I think this is why some of the smartest people in the world have concerns about AI, is that I'm not so sure that you can have all the benefits of it, thinking outside the box, without also having to get exposed to manipulation. So I do think it's a new frontier, and it's going to be very interesting to see. And as this committee goes down through here, that some of the stuff that we bump into and learn as a group. So I appreciate being on the committee and wanted to vote that I'm present, and look forward to participating. But thank you.
Thank you. Senator Thomas.
Dr. Baumgartner, we are charged with, at the end of this task force, coming up with recommendations to send forward to the General Assembly, both the Senate and the House, as to our findings and what we think the state ought to do going forward. Would you recommend that we follow efforts by Florida or by Oregon and say that one of the things that Kentucky ought to do is develop some kind of state laboratory system or data information center in the medical area where we can use AI to improve diagnosis assessment or surgical treatment or long-term care options? Would you recommend that we appropriate money to do what we've seen in those other two states?
Well, so I've been in technology for 30 plus years, and we, as technologists, we try to develop things that are useful and that people will use. People a lot of times don't want this tool that you have a technology that looks for a problem. Since ChatGPT was released, I've had an opposite problem, is that physicians and others have come to me and said, I want to use this, I am using this, I'm not supposed to be using it. This was before we had rules against it, but it's useful. So this is not a technology where we think it's going to be useful for people. It is useful, and they're using it, and they're going to be using it anyway. If somebody else develops it, if it's representative of some other group or institution or state or country, then it's going to be biased towards that group, and there's not a guarantee that it's going to work for our people. So I think it's the same conversation that would have happened in the 80s, when the conversation, should we make investments in computing, and what could we do without computers right now? It'd be really difficult. So I don't think there's a question of whether you should. It would be how much can you afford to spend versus not doing anything. I think in my understanding, there's 25 different states that already have things that are going in front of their legislatures to make major investments in the many $million range in this, because most people are convinced that there's not, like, this is going to have to be something from a education, health, economic development perspective where there's no question whether you should do it or not.
Co-Chair Bray.
Thank you for your presentation. A lot of information. It's really kind of exciting because one of the things we've struggled with as a state is improving health outcomes. We kind of assumed with the expansion of the Affordable Care Act and Medicaid expansion, we'd see health outcomes improve, but we've not really seen that outside of maybe colorectal cancer or just very specific instances. As AI is used more by healthcare professionals, do you feel like we will start seeing improved health outcomes? Are we already seeing that? Could you just talk about its use by physicians to improve health outcomes?
I think the use should be by the patients. And I think the patient-centered care is where this helps the most, because we can't hire hundreds or thousands of people to have a personal assistance that can engage an individual, that can constantly look and see, is there something going on? Is there maybe something we could look at? I think the more the push towards value-based medicine will help from the standpoint of measuring things, and now that there's financial incentives and making sure that individuals are taken care of, now that there's a financial payback in saying that if I develop a device or if I give somebody a monitor and I avoid them coming back to the hospital, there's ways to fund that. So I think we need to look at it from a patient perspective, less than a provider perspective. Now the providers benefit too, and that assistant that's doing all that legwork that we're currently not able to do are things that can be done safely by AI. I can create a protocol and have somebody be engaged and do an assessment and be able to get that information back or collect their information. Those are all technically feasible, doable. We do it today. It's just not being done at a scale. So I think there's the really whiz-bang discovery things that will exist by having a lot of this information and safely collecting it. But the thing that we could turn around and do right now is more of the personalized health and assistance that for things that we already know how to do.
That's really interesting. And then one more follow-up, if I may. So we know that Kentucky's facing a physician shortage. Over the next 5-10 years, I could see how not only is this a tool that needs physician oversight and but just take like a radiologist reading an x-ray. I could see a scenario where AI does the preliminary work and then it's looked at and confirmed, or something else may be spotted. How do you see this playing out long term with physician shortages or with manpower? I know you mentioned earlier, talked about the scheduling, how you all are using it, but is this a tool that could help augment some of those shortages?
Well, we know even in the area of radiology, they mentioned that depending on the type, that there's all kinds of other case notes that need to be written, volumes of case notes, before they can make any kind of diagnosis on the actual radiology readings. Those, in some cases, are being used. AI tools are being used to distill those case notes into information that probably wouldn't have been read otherwise. So you're being able to get those things out. Areas where we're using AI right now, we're taking human phenotype codes and pulling them out of case notes in these genomic reports, because there's a million variants between you and I, but there may be 30,000 by the time we look at ones that may be of concern. It's being used for that. Now, those are all things that can be verified by human. So it's the efficiency. Limiting the number of images the breast radiologist reads. I think they have something like, there's so many slices, they have something like 3 minutes or 2 minutes to make a diagnosis on something. We know that eliminating a large portion of those slices so that you can narrow down on the ones that are confirmed, those are something that AI can do very accurately. So I think you're looking at this would be more of the assistant on the physician side.
Thank you.
Thank you so much, Mr. Bumgardner. I thoroughly enjoyed your presentation. I think that you've given us a lot to think about. And at the end of the day, all of us represent Kentuckians. So our best interest is your best interest in making sure that that data and that service is providing better healthcare outcomes for those we represent. So we'll have to think about some of those challenges that you laid out, and I appreciate your willingness to share them.
Thank you.
Next, we're going to have take out from the insurance side of things. Hope McLaughlin and Anthony Rodriguez are here from what we know as Anthem Insurance. And if you'll introduce yourself and talk a little bit about how Anthem is using AI in the insurance space.
Sure. See, did that? Okay. Good morning. I'm Hope McLaughlin, Senior Director of Government Relations for Elevance Health for Kentucky. As Chair Bledsoe said, you're most familiar with us as Anthem Blue Cross and Blue Shield. Many of you have our health insurance card in your wallet today. We have been serving Kentucky since 1938 for over 86 years, and we're very proud that we serve every county in Kentucky in the commercial, Medicaid, and Medicare markets. We have about 1,700 employees in Kentucky, so we're an important part of the economy, bringing healthcare access across the state. Thank you to Co-Chair Bledsoe and Co-Chair Bray for inviting us here today to talk about how we use artificial intelligence to simplify things for our customers, our members, and providers. I work with you all on a regular basis, but I'm not an expert in AI. So I have my colleague here with me today, Anthony Rodriguez, who is the Director of AI Strategy and Planning for us. And Anthony, if you would like to introduce yourself and get started.
Sure. Can everybody hear me okay?
Yeah, we can hear you, Anthony.
Sure. So Anthony Rodriguez, I'm based here in Atlanta, Georgia, so presenting to you virtually. I'll talk a little bit about what we're doing at Elevance from an AI perspective overall, with some examples of where we see opportunity overall in the space. So at Elevance, we're leveraging AI to enhance the healthcare experience for our members and really focus on improving their health and well-being. To really embrace the opportunities around AI, we've worked to focus and build out a robust, responsible AI governance model that's really based in the National Institute of Standards and Technology and kind of standardized frameworks that have been put out there, but focuses on how do we be intentional on where we're using AI, making sure that it governs, all aspects of privacy, data usage, and represents our core values and principles. The most important thing, I think, is, guiding us on how can we be strategic, intentional in addressing the correct problems and solutions and the correct aspects of our business, as it's not suitable for every opportunity that may be out there. Throughout that process, we look at all aspects of an AI solution, how a problem might be solved, how we counteract any potential bias, risks, and ensure that a human is in the loop as part of any solution that's put forward. We really want people to be in front of any kind of decisioning that's made, but really focus on how can we leverage AI, mitigate risks, leverage the data that we have to help better decisions be made more efficiently throughout the whole process. Overall, I think we see a lot of opportunity offered by AI as a whole to really improve the experience of the providers, members, and associates that we serve. A few examples of where we're using AI today. Prior authorization is a big area that I think comes up in conversation a lot. We have not and do not use AI to deny any kind of request for prior authorization, but we do focus on, where there are opportunities to leverage AI responsibly, where we're able to extract, organize, summarize, compress, and synthesize all of the relevant information that's within our members' medical records that can further automate the end-to-end clinical review process. That's a process that there's definitely opportunity to help streamline, and being able to better manage the information ultimately helps us to do that a little bit better. The goal here is really to leverage AI to automate and improve the speed of approvals throughout the whole processing piece and allow our clinical staff to focus on more complex cases and making sure that real people with clinical training are focused on critical cases and handling anything that could not be automated at that point. So it's really kind of optimizing capacity so we can focus on the important areas. We really want these solutions to really allow our care providers to practice at the top of their license, accelerate diagnosis and treatment of our members, and ultimately increase access to care and the timeliness that they're able to receive care. For our members, access to care, but also accelerating just overall scheduling services, their ability to get what they need by trying to mitigate some of the cumbersome process that they might be accustomed to as part of the prior authorization process today. Part of what we have done in this space is develop an AI solution that matches fax documentation with corresponding medical policy information just to expedite the review in that one piece. That's something where we take a solution where we feel like it's appropriate, we feel like it's helping accelerate part of a process, and we look for how can we replicate that at other parts of that overall prior authorization piece. So one piece of data match, how can we go and expand that to help it create efficiencies in other parts of that? Another major part of our operations is our call center. So we leverage Gen AI capabilities to support our call center associates for all of our Medicaid markets and lines of business. This is really used to help answer common inquiries, reducing overall call time, and just improving the speed and the accuracy that we're able to get for known questions that we get on a regular basis. Reduces a lot of the kind of wait times and abrasion that might happen within a call center setting, but ultimately helps get our members answers more quickly. We do use large language models to quickly review members' plan documents, answer common questions related to that member, and create some aspect of personalization. And all about, again, kind of getting those answers more quickly, especially within a health setting. We do use AI as well to predict and proactively engage members as they reach out to us. So when we think about members that are coming to us, how can we proactively kind of address what they might be seeing or what they might be reaching out for? We're on track to reduce up to 3 million member calls using AI prompts that allow us to reach out to members via text or really any channel, any communication channel of their choice to resolve problems before they contact us. When we think about personalization and proactive member outreach as a whole, Really combining the power of machine learning and data science creates some ease and convenience in how our members are able to hear from us, makes it a little bit simpler to engage them, start conversations, and ultimately lead to better health outcomes. AI models we have in place work to identify members who may benefit from this, and then ultimately help personalize our messages. Specific to Medicaid, we're working on launching a proactive member engagement program soon, which will include reminders to schedule preventative visits, such as flu shots, and ultimately help them find access to any kind of care that they may be looking for. Overall, there's a lot of opportunities with AI that we see throughout our organization. Internally, we're looking at how can we leverage Gen AI and the prevalence of LLMs for knowledge management, managing large document sets, doing policy comparisons, contract comparisons, and whatnot, just to better manage the vast number of information that I think is part of every aspect of our process. From a member provider perspective, we covered a few examples, but really looking at how can we compress all of the clinical information, claim level information, synthesize that back to our providers, and ultimately allow them to make better health decisions, leading to better outcomes for our members. From a policy perspective, we really think that policy should focus on mitigating the risks of AI and thinking about how do we advance the benefits. We align with a lot of the major policies that are in place and look at how do we kind of manage within them, but also how do we focus on new policy efforts towards the higher risk areas, applications of AI that may impact members directly, may impact clinical outcomes, really focusing there as kind of a key opportunity area. So with that, I'll pause. If there's any questions.
Thank you so much for your presentation, and stay on. We do have a few people signed up, so we'll start with Representative Lewis.
Sure.
Thank you, Madam Chair. Hope, always a pleasure to see you. Given our previous presentation, we talked about advances in diagnostics and leading to more effective treatment, more targeted treatment, better health outcomes. And then hearing Anthony's presentation, you're looking at efficiencies, you're looking at better treatment options for our patients. What impact do you see AI having in terms of healthcare costs, insurance premiums in the future?
So, Representative Lewis, that's a great question. And I think that our focus is taking everything that we have and streamlining the process. And so we want to make it easier for patients. We want better outcomes for the patients. And certainly affordability is a priority for us. And you all hear me talk about that a lot. I hear this group talk about, there are enough dollars within the healthcare market to make sure that that everything that happens needs to be covered. And so that's certainly a priority. I think by the nature of streamlining and prioritizing efficiencies for patients, providers, our customers, and our members, hopefully it will lead to that. But we're in the infancy of that, so we don't have any outcomes that we could share on that. And Anthony, certainly, if you have additional feedback or thoughts on that, I welcome you as the expert to hit on that one.
Yeah, the one piece I would add, Hope, is that overall, when we think about our strategy around AI, it is to create those end-to-end efficiencies, which should translate into reduced costs and improved outcomes. But I think we're still trying to establish the proof points. We've been working with AI for a long time, but I think it's becoming more prevalent now in the industry, in the market, and as a whole. So while I think we have a good idea of what those proof points might be, there's a lot to be proven in terms of how we get kind of really specific on where what the anticipated outcomes will be.
Thank you, Madam Chair.
Sure, Senator Thomas.
Mr. Rodriguez, I want to go back to the beginning of your presentation, in which you said very early on that you don't use AI to deny claims. But then you went on during your presentation to talk about how AI is used to synthesize information, look at similar types of claims and ailments, and you use that to approve claims. I'm going to ask you, doesn't it stand to reason if AI is being used to approve claims, then after you look at the total number of claimants, by its very nature, AI is not going to say that everybody should be approved. And so, in effect, AI is going to be used to eliminate certain people or deny or suggest anyway that certain claims should be denied. That's part one of my question. Part two is, and this goes back to Senator Maris's point, which is very appropriate. We know that there's bias in AI that we're working every day to try to eliminate. Wouldn't there be a problem as AI suggests that certain claims to be denied, that there might be certain biases in denial of those claims? So there's a part A and a part B to my question. Please answer that for me.
Anthony, go ahead.
Sure. I would say we could start with part A. I would say while we do look at how do we leverage data to approve the data we have to approve claims where we can to expedite the outcomes, get to the approval more quickly. On the other side of that, claims that are not automatically approved are reviewed by a part of our clinical staff. So we're not necessarily creating, bifurcated two outcomes one way or the other, but we're trying to limit the manual review and the manual effort that someone would need where we know it's a known situation and an approval is suitable. That list of approvals and automated approvals, I'd say, is relatively small in the prior authorization space because we do feel a person needs to be in the loop for reviewing each one of those that comes through so that we're not automating incorrectly. We're starting very small in doing that, but we do think the goal is to approve as many as we can with as much data and confidence as we can. The second piece around bias and how we manage that on an ongoing basis, part of our responsible AI framework for any solution that has any bit of AI component to it, whether it's Gen AI or predictive or more traditional methods and techniques, we do go through a pretty thorough analysis that evaluates how good is the data that we're using? Are there known data quality issues? Is there known bias that we are not comfortable with and we want to stop the development or take a different route? And then what is the potential to establish bias? A lot of times with AI, as a solution is developed, there may not be bias, but as you go through and as it builds up some history of operating, it could create bias. So how do we manage that going forward? And what's the potential risk of that happening? All of our AI solutions are monitored on a consistent, always on type basis where we're looking at outcomes that come through, any kind of variations that might be of concern, and have a focus team looking at how we would manage that on an ongoing basis. So I'd say it's something that we try to address proactively. And because of the thoroughness of that initial review, there's a very small subset that actually makes it into a production environment based on our comfort levels. So I hope that answers your question.
Nothing else at this further time, Madam Chair.
Thank you. Co-Chair Bray.
Thank you all. It's really exciting to hear how you all are using AI in the prior authorization process because as you all know, every year there's a bill filed on modifying the prior auth process or making it more efficient. And I do think that eventually this will eliminate the need for prior auth. Just for my clarification, I know you all have touched on this several times, and even in, when responding to Senator Thomas, I just want to make sure I completely understand how it's used now. So it sounds like you all are using it in a very limited process to start with in order to approve as many things as you possibly can. And when it flags an issue or it may see an issue, that is reviewed by a human. Is that correct?
Anthony, do you want to respond to that?
Yeah, that's correct. We look at the data and try to figure out what are the right situations that are suitable for approval, and we want to automate those as soon as we possibly can, within the level of governance that we have, making sure it meets all of our responsible AI standards.
Okay. So as you, since you all are starting small, and as you, I guess what are you seeing as it goes through the prior auth process? Does it look like that it could be a long-term solution in that space if it's expanded?
Anthony,
I think-
go ahead and answer that, and then I have a couple of data points I want to share with you as well.
Awesome.
I do think that there is a long-term solution to kind of optimize all aspects of prior authorization. I think the data management and being able to synthesize the information that is needed to process a prior authorization is one piece. And then the actual decisioning and support for decisioning is another piece. So I think there is a pretty strong opportunity and roadmap to scale that out and make a much bigger impact across prior authorization as a whole. And that's part of what we're very aggressively kind of planning and developing internally right now.
Yeah, thank you, Anthony. The one thing I want to share with you all, since we're talking about, I didn't intend for this to turn into a prior auth conversation, but I do spend most of my waking hours talking about it these days, so it's appropriate. I think that this is a piece of the solution. Certainly, you know, Anthony really emphasize the importance of having humans in the loop and the way that we utilize this, and that responsible AI is our priority. But it's important to remember that we have done a lot of other things in the prior authorization and process as well. And across the country, we're seeing 70% of our prior auths approved instantaneously, and 95% of those are approved within 24 hours. And so I think that it's important to have like the full picture of this. And Representative Bray, I think that your thought about how far this could and how much this could help us in this space, I think is certainly spot on. So thanks for the question.
Thank you.
Senator Thomas, do you want to respond briefly to that?
Yes, Hope. I think we have to understand, and it doesn't surprise me what Mr. Rodriguez said. I think we understand that AI is now being used to determine whether people receive certain treatment. Well, again, are they authorizing certain procedures, certain medical treatment to be approved or not approved? I mean, that is going on now, Hope. We not. I mean, that doesn't surprise any of us. When you talk about prior authorization, Hope, people see that as wellness being sick. I mean, when you're the person that needs, you know, an X-ray or needs an MRI, and you're waiting on someone to approve it or not approve it, I mean, that's a critical, to that individual, that's a critical healthcare decision. So we can't avoid not talking about prior authorization as we look at AI and its uses in this state. And so the question becomes, okay, since it is being used to approve, or by the opposite side of the coin, not approve certain authorizations, you know, how does that impact wellness in this state? How does that impact accessibility to healthcare in this state? What biases are in place that might unjustifiably deny a person a certain procedure? All those things have to be considered, Hope.
So, Senator Thomas, thank you. I appreciate that. And I want to be clear. I speak for Anthem, Blue Cross Blue Shield, Elevance Health companies. I don't know how other insurers are using AI or not in that space. But I can tell you and reiterate what Anthony said earlier. We have not and do not use AI to deny prior authorizations. And so saying that AI denies care would not be accurate for an Anthem member. And we are hoping that this streamlines processes and improves healthcare outcomes by getting care to patients faster than it's happening currently, and that it also alleviates the burden for physicians as well, like we talked about, and like Dr. Bumgardner talked about as well. I think that that's a really important piece of this to consider, and I think that the being responsible about it is certainly our goal, and that's why we have not and do not use AI to deny prior authorizations.
I appreciate that clarification. Okay, thank you. Senator Meredith?
Thank you, Madam Chair, and great discussion, interesting discussion. I think there's a great potential for building a symbiotic relationship among insurance and providers and patients if we have a common goal. I'm not sure we're on the same page with that. The discussion about pre-authorization, I think that could very well be expedited. And I'm not sure I understand the hesitancy of that. But what other functions can we address by using AI? Because Senator Thomas knows we had this conversation just at the previous meeting about the cost of health care. And a big component is the administrative burden. We're spending 30 cents of every dollar, which is double what other industrialized nations are doing. I think AI could truly impact that. So I'm wondering if we're focusing on that as well. And, with pre-authorization for so many things, it's really just an algorithm to determine whether it should be approved or not. So again, I don't know why if we really implement this technology, that those things are almost instantaneous, and we should take advantage of that. But there's so many other areas that we could address. Are you folks looking at those as well? And again, I say that with the caveat that I'm not sure people understand the crisis this country is facing with the cost of health care. Average American can't afford it anymore. And it's going to collapse our economy if we don't address this. And I had this conversation before. We're at 18% of our gross national product. We're spending $13,000 per capita on health care in America. Next closest nation is Germany at $8,500. China's at about $875. We can't be competitive in the international market if we don't get control of this. And that's where I think the symbiotic relation can exist. But you folks can increase your profits, but you can also increase productivity, particularly in our rural areas and most disadvantaged, if we work together. One of the simple one that comes to mind to me is credentialing. And we try to address this one as well, but there's so much data out there on every provider in the world that I think that can almost be instantaneous. And it's so burdensome and so cumbersome and so expensive. But are we looking at that function? And what other functions are we looking at to truly reduce the administrative cost and get it where it needs to be?
Sure. Thank you, Senator Meredith. And you're right. We have had this conversation many times, and I think that we'll have it several more times over the next several years. I think that we have outlined some of the things that we're doing to help increase patient accessibility to healthcare, certainly, and help physicians view those things. Some of the things that Anthony mentioned in allowing data to be compiled, I think will help with those types of things, whether it's, reviewing provider information or reviewing patient information. And ultimately, time is money. And so as we reduce the time to do anything within healthcare or make it easier to access for anybody in that healthcare chain, whether it's the member, the customer buying the health insurance, or the physician, I think that that's going to be an improvement for the overall process and hopefully continue to create efficiencies in healthcare that will make it easier for everybody, certainly. Anthony, is there anything, related to any provider-facing information that you would like to share, kind of to touch on some of Senator Meredith's questions?
Yeah, absolutely. I'll say one thing as well. When we think about opportunities for AI as a whole, kind of like we've discussed, where there's decisions that need to be made throughout the healthcare process, the claim process, and encounter, whatever piece of that you're looking at. But you need information to make those decisions. If we distill it to that, that is where we're trying to create and look for opportunities where we can leverage AI and LLMs and some of the techniques that are more prevalent now with Gen AI and LLM specifically. How can we produce those data points accurately with high confidence to then accelerate the ability to make a decision, keeping a person in the loop, keeping a physician in the loop, to be the one making that decision, but not having to spend the time it may take to go through medical records or any of the kind of associated history and documentation that they may have to pull the information to make that decision. So I think generally that's where we are looking at opportunities. How do we shorten the time that it takes to make a decision by being able to compress and leverage and summarize, organize all of that information that currently across lots of processes and decision points, a lot of people spend a lot of time going to look for those data points and information and produce them back. So again, just to kind of distill it to that, I think that is where there is the biggest, most prevalent opportunity, not in any kind of decisioning, but just in shortening the time it takes to make a decision and ensuring high confidence and accuracy in what's produced to support those decisions.
Well, I think the greatest opportunity for us is reducing the administrative burden, as I've already mentioned, but even bigger than that is improving the health of our population, which has just become a buzzword. Mm-hmm. And it shouldn't be, but the challenge is even greater in rural communities because of lack of healthcare providers. But that's what the greatest potential savings are. So should we look at two different models, possibly an urban model and a rural model, and give exception to some rural communities to help those particular providers become more efficient, more productive, because the savings we could be realized with that will certainly, I think, outweigh any costs. So we may encourage them to do that.
You know, when I think about it, really just as a consumer of healthcare, the thing that I'm most excited about AI and other items is that healthcare is complicated. We all know how complicated healthcare is. It's complicated as a person when you have, 10 different specialists that you see and you go into your physician and you can't remember what the doctor said to you or what the doctor prescribed you. And I think that that's a great way that we can improve this and bridge that gap between the rural and the urban and the rural communities, because there are certain healthcare providers that are only going to exist in Kentucky, unfortunately, in the more urban areas, those specialists that I referred to. And so I'm hopeful that in the future that AI can help bridge that gap on what those providers are doing for patients. And it really does allow providers in rural community to practice at the top of their license, as Anthony mentioned earlier. And so they can take that data quickly from those other folks and help them make a decision for their patient more quickly when they are seeing them in their office closer to home. And so I'm hoping that as this improves and we get more use out of it, that it'll connect those dots both on our side and the provider side, and that we can work together to bridge those gaps for our members and the patients.
I appreciate that, but one of my concerns is even with something like telemedicine, great advancement we've seen, but it's not going to address the issue of the health manpower shortage in rural Kentucky. It helps a little bit, but not going to address it, and we can't discount that. If there's one absolute about all of this, is just like politics, all healthcare is local.
Yeah.
And if we don't embrace that and try to address that, I'm not sure we'll see the advances that we need to make. And again, there's got to be a sense of urgency to this, because I think the system's on the verge of collapsing.
Senator Meredith, I look forward to continuing to work with you to continue to find those solutions for rural communities and how we bridge those gaps, for sure.
Thank you. Thank you, Madam Chair.
Thank you. And I appreciate this dialogue and the discussion. I myself, on a personal level, am not an Anthem subscriber, but I've had more surgeries and procedures in the last 9 months than I've cared to think about. And from a lot of different providers who offer different specialties for different things that I've needed. And, my chart has kind of saved my life in many ways. I just say, here's what they've done. Yeah. Because it was very technical. And I was trying to explain to different experts on different issues who've seen me at different times in this process how everyone's working together. And this is all about patient health care. Mm-hmm. This is about me getting the best help I can get for myself to feel the best I can feel. And it takes a collaborative effort. And I would even mention on the pre-auth, there's a number of things that were, I don't want to say elective, but they were not time sensitive. And so I was waiting to get these certain things in, and there'd be a cancellation. Great, the cancellation fit with my schedule, the doctor's schedule, but I couldn't get the insurance to sign off quickly enough. That was a missed opportunity. That meant, in some cases, if they couldn't feel that cancellation, that doctor wouldn't provide that surgery. The hospital that would have done it wasn't using the maximizing time. And there's a lot of efficiencies in time that are in that system. So anything we can do to provide, I think, better outcomes for people is what we're looking for.
Yeah.
And I think I appreciate the commitment of Anthem, and I'm sure others to that effort. So thank you for your testimony today.
Thank you.
And then lastly, we're going to take a look at how we as Kentucky's Cabinet for Health and Family Services is also looking at AI. With us today is Jennifer Harp and Ruth Day. Thank you all for joining us today and providing a little update on what we are looking at as a state. Just introduce yourselves for the record, and then you may have the floor.
Of Application Technology Services. Yes, ma'am. Oh, no. It was a muted green. Okay. Jennifer Harp, the Executive Director for our Office of Application Technology Services within the Cabinet for Health and Family Services.
And I'm Ruth Day, the Executive Director of the Commonwealth Office of Technology and the Chief Information Officer.
So we do have a presentation. Oh, perfect.
If it'll pop up. And let's see. Well, and I think you can just scroll and it should be
awesome.
There.
Thank you. Okay. So I'm here today on behalf of Medicaid as well, since Medicaid is within our Cabinet for Health and Family Services. What our OATS team does is we do support all of the agencies within the Cabinet. So we want to look at it holistically, look at AI holistically across the Cabinet. So we'll first talk about kind of our CHFS strategy and vision for AI, and then go on to our current AI usage and then future use cases. So within CHFS, we do believe that AI is there to help us improve, help us identify efficiencies, and improve our business processes. We are looking at AI as a tool, not an application. We do also understand that these new technologies are rapidly advancing, and there's also concerns. So we want to make sure that we are cognizant of those, that we have policies and security and all of the folks that need to be at the table having those conversations. We do want to think big, but start slow. We are tracking all of our other peers, other state HHS groups within the various states. We're looking at our federal partners. So within Medicaid, we do look to the Centers for Medicare and Medicaid Services, any of their federal guidance that comes down. We will also follow any of those regulations. You've heard a lot about responsible AI. We believe in responsible AI. We also believe having a human in the loop within CHFS. And then our comprehensive governance group. So we will be establishing a governance body within CHFS. That governance group will be looking at all of the various use cases, trying to understand what the purpose of it is. Are we following all of our responsible AI processes and procedures, and then approving. And we'll continue to work with our COT partners. COT will be at the table with us. COT does review all of our IT projects, our IT tools, so they will have that oversight as well. And we do plan to use proof of concepts to ensure that the purpose or our goal for using an AI is met. Responsible AI. So here are some of the foundations that we're looking at. Privacy, obviously, is very important. Fairness and bias. I know you're, concerned about bias. We do believe that everyone is responsible for bias in ensuring that we are being fair in all of our use cases. Transparency. We want to make sure that folks that are using AI understand it is AI. Safety and security, validity and reliability. We want to make sure that the data and the tools that we use, the models that we feed, the data is reliable, and then accountability, again, with that human in the loop. So CHFS does have an AI policy. It's an AI and Gen AI policy with those responsible AI as our framework. We did incorporate some of the guidelines from the 2023 White House executive order. We also looked at a number of other states that had AI policies at the time, incorporated some of those policies in there as well. We've worked with COT partners. They also reviewed and approved our policies as well as some of our other agencies. And we know that, again, with the rapid advancement, we're going to be looking at our policy at least quarterly and continuing to adjust to meet the need. So some of our usage strategies is we do anticipate that all of our AI use cases will be reviewed by our governance board, including those third-party tools that we want to leverage. Use cases at this time, again, thinking big and starting slow, we are not going to incorporate sensitive or confidential information. We also want to target for our internal audience, so our workforce. We're not ready to go out there and release Gen AI to all of the public saying, hey, come, let this give you your information that you need. We want to look and find those efficiencies internally first, understand where AI is going. So not considered, just talked about it, anything with sensitive or confidential information in the public facing, or anything that COT also does not authorize use of. Today within CHFS, existing use cases, and this is just AI in general, we do have within our pharmacy benefit manager, they use optical character recognition. OCR has been around for quite a while. We also use that as part of our integrated eligibility and enrollment system. When we do receive certain documents via mail, it can be scanned and uploaded into our systems. We do have a chatbot out on our website today. It is very simplistic chatbot. It's been there for a couple years. It's more of your simple questions, right? The FAQs, we have not expanded it for any of the more generative AI. We also have a recommendation engine as part of our Connect resources. So based on the information that you put in and the information of our community partners, it can come back and provide recommendations of other services that may be beneficial to you. And then our customers' insights, it's within our IS, and kind of it's surveys to request feedback from end users when they use our system. Because one of the things we want to do is we always want to look for areas to improve, right? We're not perfect and we understand that. We never will be. But as long as we're continuing to improve, that is our goal. Future use cases, there are so many. There's so many, and with the different individuals that spoke today, there's a lot of potential use cases within CHFS. And again, we're really excited about these. But we also understand we need to consider them. They need to be vetted. They need to go through all of the various approvals. Policy engine, this is kind of what we call it internally, where we load all of the policy for certain agencies. And it helps our workers to identify the policy without having to go in and do the keyword search, right? Without having that policy speak. It has that normal person speak, and it can help the worker. But with that, because of the transparency, we also want to make sure that we are going to provide the workers where we receive that information, point them to that specific policy. We're also going to, with that human in the loop, we're going to have a feedback option, right? Thumbs up, thumbs down. Other potential options that we've just very discussed at a high level, nothing has gone on to be approved. Training assist. It takes workers, no matter what field you're in, forever to get trained, it seems. So by building in some additional AI capabilities to support training, maybe we can get our workforce out there a little bit quicker, right? Maybe they can continue to have training while they're using this system, and it can provide recommendations on where to go next. Additional case insights, you've heard folks talk about call centers. There's a lot of use cases around call centers, right? We do think that is very exciting. Real-time document processing, taking that OCR capability and expanding it a little bit more so that when someone is uploading a document on one of our systems, that it can tell them in real time, hey, this name on this document does not match this document, right? To reduce the need for additional requests for information or additional back and forth. Let's give folks at that point in time information at their hands so that they can make the decision. Again, there's so many other use cases. These are just a couple we've put on here. Okay, and I know I talked really fast.
That's okay. Ms. Day, do you have anything to...
I don't have anything particular to say. I was here today because I wanted a show of support so that you guys understand how closely we work together. In fact, Jennifer has been kind enough to volunteer to chair a committee of IT folks that will be looking at artificial intelligence across the executive cabinet. And it's also important that we work closely together because, as Jennifer describes certain use cases, it's important for COT to learn how they use them, and then they can in turn go out to other agencies in the enterprise and use those same tools maybe in a different application.
Fantastic. I appreciate both of those comments. I have just two questions to kind of start us off. You mentioned the governance board under the cabinet. Who is represented on that governance board?
It is yet to be established. We are working on it. What we do anticipate is not only folks from our IT shop, but individuals from each of our agencies within the cabinet, within the secretary's office, as well as our partners with COT.
Okay, so internally
Yes, ma'am.
exclusive. Okay, that's good to know. And then two, one of the things that I thought was interesting about Dr. Bumgardner is how UK is using it to better serve healthcare and healthcare outcomes from a patient perspective. I think we look at just Medicaid, we're extending benefits to Kentuckians. How are they then responsibly using that healthcare through follow-up, through taking meds, through doing the protocol as established? Do you see that as a tool, or have you all discussed that in terms of seeing where patients are actually doing what they're being asked to do?
So we have had very high level conversations, no specific use cases. However, being able to leverage Gen AI tools to look at our data and to analyze our data, we do know that that's going to be a really big piece coming up that we're really excited about. It just gives more information to our policymakers more timely.
Agreed. I think as policymakers up here, we're looking for what's the best use of resources of taxpayer money, which also provides really good health care to people who need it. And there's a balance between those two things, and we're, I think, trying to do our best to help be wise about both. And so I think we're very interested in those conversations. Do you have a question? Yes, Representative Miles.
And I guess, thank you, Chairman. I guess you all are looking at it from a standpoint of, on your all side of things, of how to use it. And I thought it was interesting. It seemed like it was reverse on the presentation from UK, that they're more concerned about the receiving end of it, so to speak, of how that helps. So I guess I would hope that you all would try to kind of look at it indirectly of what I think you were kind of getting at, the consumer, of the person that's actually applying for a service or needs help with a service, or how you follow up with that person to make sure that they're showing up when they're supposed to show up. I know that's probably one of the biggest complaints that I get from providers of Medicaid that accept Medicaid, of people actually showing up for their appointments and things like that. So I guess it seems like you all are looking at it from reverse sides of the direction that you're using it. So I would hope that, quite honestly, both sides would consider it from both directions.
Yes, ma'am. Thank you. So we are looking at it from both sides. Again, kind of back to that think big, start slow. It's rapidly advancing, right? There's new LLMs that are coming out daily. And so to really understand that, we don't want to just go throw something out there and say, oh, look, this looks best. We do want to focus internally, make sure we have a good handle on it, on what we're doing before we do send it out. I completely agree with you, being able to have nudges. So we do nudges and reminders to folks for various services across the cabinet, and we have found a significant improvement in responsiveness to those.
To the extent that we use artificial intelligence to, again, take out that redundant work, low judgment we talked about before, that's where we really get the value to the citizen. We free up those resources that are citizen facing so that they can spend more time doing exactly what you just said. So I do think that is the focus of what we're trying to do. We're trying to lower the administrative burden to allow to free those resources to be more interactive with citizens.
Senator Meredith.
Thank you, Madam Chair. Through all three presentations, we've heard about efficiencies. Almost every organization of a service nature, 70% of your expenses, labor. So I would think increased efficiency means reduction in labor. Have you all given much thought to that? Now, I assume part of that answer as well, this new technology is going to create new jobs, new opportunities. But are we prepared for that as well? Because I would think that would take a great investment in education as well. But how do you see future workforce demands?
Well, the flip side of reduced labor might be improved service. So, I think at this point we're really not looking at reducing labor. I think we're just trying to leverage and make that labor more productive. And certainly there will be jobs that will come out of the whole artificial intelligence field, as there has been an emerging technologies always do.
Into that within CHFS, some of the use cases we're looking at, for instance, the policy engine, right? Being able to allow our workers to do a search on policy without having to thumb through multiple documents, right? Bring it up to them so that they spend that time, that extra time, whether it's 10 minutes a day, 20 minutes a day, 45 minutes a day, interacting with the client, right? Figuring out what it is that the client needs. So it's more of those mundane tasks, the things that are more of the administrative, that we're trying to help find efficiencies there so that they can take their time and focus on the client instead of, I've got a waiting room full of people, I need to hurry up and get through.
What do you need from our legislature to be successful in your efforts?
Well, the first thing I'm always going to ask for is money. You can ask my husband. Support, honestly, of course, funding. Whether it's for staffing with skill sets and AI, to be able to look at these tools, to be able to bring these tools in. We continue, as I mentioned, to talk with other states to understand what they're doing, leverage some of their learnings and some of their findings. But at the end of the day, it's support.
And I appreciate that. And, it's part of my personal philosophy that every dollar we spend in state government, there should be a measurable return on investment. And I'd certainly willing to give you that support. But I'd also ask you, how do you going to measure return on investment, in which term is a measure of success? And it needs to be tangible. It needs to be objective. And so I just want to plant that seed with you.
Absolutely. Thank you.
Thank you. Thank you, Madam Chair.
Thank you. And Senator Meredith asked the question I was going to ask, is what we can do to be supportive and think about being good partners to you as you develop kind of an AI policy for the state, and how we can be mindful of application and tools that make sense for better outcomes for Kentuckians and also for taxpayers. And to Senator Mayor's point, it is that, and we want to be wise about both things. So as you move forward with that, please do keep us in the loop of what you're working on and ways we can be helpful to look to maximize those services.
Yes, ma'am. Absolutely. And that's another thing, too, is that for each of our POCs, or as we implement these tools, we do want to look on what that ROI is. So we'll have data to be able to show, hey, look, this is what it has done. These are the efficiencies we've gained. Some of the things in IT, we know that they don't come back to say, oh, look, we've implemented this system, so it saved us, $1 million. Some of it's more intangible things, right? So we will be capturing those items as well.
Good. And I think just to wrap it up, I think one of the interesting things about Dr. Bumgardner's conversation about Kentuckians is want to make sure our data helps Kentuckians. And there could be a really good symbiotic relationship between our universities and what they're doing, and also the data for Medicaid and for our own things here that maybe could provide better outcomes. And I'm not sure how that looks yet, but maybe that's a conversation we can continue to start as we look at funding, kind of the global picture of how we provide good health care for our state.
Yes, ma'am.
All right. Thank you all very much. Our next meeting